Good afternoon, everyone, and thank you for joining us today. Today, our webinar session is Palliative Approach to Care, Living and Dying Well in Alberta. We have some great distinguished speakers and presenters today. First is Michelle Peterson Fraser, who is the Provincial Director for Palliative and End-of-Life Care with Seniors Health and Continued Care at Alberta Health Services. Michelle has worked as an RN on the front lines of both oncology and palliative and end-of-life care. She has also held numerous management roles, including the Director of Resident Care and Hospice setting. Emma Buza is the Provincial Lead for Palliative and End-of-Life Care Practice Development with Seniors Health and Continued Care Portfolio at Alberta Health Sciences. She has a background in population health with a master's in biotech from Columbia University. She has taught and published work on health system evaluation and ethics with a focus on palliative and end-of-life care, homelessness, prison health, as well as mental health and substance use. Dr. Meena Kalluri is an associate professor of medicine at the University of Alberta, Edmonton, Canada. She completed her residency in internal medicine at Drexel University College of Medicine, Philadelphia, and fellowships in pulmonary and critical care medicine at MUSC in Charleston, South Carolina. She's also the founder and director of the Multidisciplinary Collaborative ILD Clinic at the University of Alberta. She has developed a patient-centric approach with early integrated palliative care intended to improve health-related quality of life and the death and fibrotic lung diseases like IPF. Her clinic has received numerous awards for Innovation Award and most recently by the Canadian Foundation for Healthcare Improvement as an emerging innovation in palliative end-of-life care. Dr. Kalluri is also a member of the Medical Advisory Board of the Canadian Pulmonary Fibrosis Foundation. Michael Wilson is an MN, NP nurse practitioner with the Alberta Health Services North Zone Palliative Care Team West. He has been employed as a nurse in Alberta Health Services North Zone communities since 1995. He has had the privilege to help many people in many different areas like acute care in small rural hospital, population, public, home care nursing to clinical quality improvement. As a system transformation leader, he empowers others to strive for quality improvements at the individual unit and zone levels, encourages patients and family-centered care by having providers ask patient and families, what matters most to you? Amy Regnier is an MN, NP, BA nurse practitioner from the Alberta Health Science North Zone Palliative Care Team East. She started her career in rural hospital in 2004 and has never left. The challenges and variety of rural practice challenged her and gave her a great sense of satisfaction in her work as a nurse. She has practiced in surgical, medical, obstetrical, and palliative care, sometimes all in one day. Palliative care became her focus and passion in 2006 after some difficult experiences at the bedside. In 2011 to 2013, she joined a palliative team in the North Zone as a CPRN, the program at the time, which was much different than the program that they have now. And today, I just want to thank them again for making this wonderful presentation. I hope everyone enjoys. Thank you.
All right. Well, thank you so much for the opportunity to present today. I'm just going to do a quick sound check. Can you hear me okay?
Yes, we can.
Yeah. Okay, great. All right. So just wanted to let you know that I'll be starting off. It's Michelle. And also that at the end of the presentation, there definitely will be opportunity for questions. So I'll just ask you to switch to the next slide then, Emma. This is just our standard copyright slide for Provincial Seniors Health and Continuing Care with Alberta Health Services. Next slide, please. All right, so some of the objectives of this presentation are to learn about the provincially agreed upon definitions of palliative and end-of-life care, as well as the palliative approach to care, and what they mean philosophically, as well as what they mean to patients and families. Also to understand how the palliative approach to care early on in the life-limiting illness has many benefits. The third objective is to learn about what palliative and end-of-life care programs and services are available in Alberta and how to access them. Also, very importantly, how to access palliative and end-of-life care supports for those living with pulmonary fibrosis. And finally, how to learn how the pandemic has affected palliative and end-of-life care in Alberta. So for those of you that don't know, in 2008, Alberta Health Services was formed and became one region with 5 zones. It is the largest fully integrated health system in Canada, and this formation gave us an opportunity to work together to provide more consistent services and supports across Alberta. One mechanism to do this was to develop a provincially agreed upon framework that guided our activities. I just would note that Edmonton and Kalluri zone are considered more urban in nature, and Central, North, and South zones are considered more rural in nature. Next slide, please. This is the Provincial Palliative and End-of-Life Innovation Steering Committee. It is multi-sector, multidisciplinary, and representation. And all of the provincial palliative and end-of-life care work is vetted through this committee. It is interdisciplinary in nature, and we have both internal and external stakeholders at the table. We actually have 2 patient and family advisors, as well as Alberta Health is part of this committee. And I'm just also going to highlight that the Palliative Institute with Covenant Health is part of this committee and has a standing agenda item on the meetings. Next slide. So before we sort of dive into the rest of the presentation, we wanted to just take some time to define some key terms that we will be using throughout this presentation. And all of these definitions have been provincially agreed upon. And when the committee was first formed and we were looking at developing the framework, one of the very first things we needed to do was come to an agreement on definitions, because that is a foundation to our work. And it took months and months actually for palliative and end-of-life care experts to come to an agreement on what these terms mean. And so we ended up having both philosophical definitions as well as administrative definitions. And on the screen are the philosophical definitions. And I'm not going to read them, but just going to say that, as you can see in the diagram, palliative and end-of-life care is a continuum of care, and it really does start at the time of diagnosis of a life-limiting illness through to the time of death and into bereavement. And then the squiggly line on the picture there shows that that a palliative approach to care can occur simultaneously with a curative approach, or during treatment. And this model of care is adapted from the Canadian Hospice Palliative Care Association and really guided and conceptualized our work. The blue, the life-threatening illness, is language that the pediatric population requested us to put in there. And I just also wanted to note that Emma is going to be talking about the pandemic and visitor restrictions and end-of-life care definition became very, very important to know that this is not when someone's imminently dying. This is a period of time of 3 to 4 weeks prior to someone's death, so that there can be that time for families to say goodbye. And so you'll note that in Alberta, we needed to really define that period of time so that people had the opportunity to say their goodbyes. Next slide. The steering committee revisited all of the definitions recently because this was something that was going on nationally and internationally. And we did decide to change our revisions to the palliative approach to care, as well as hospice care, and really just made those definitions a lot more robust and indicative of our current landscape in Alberta. We wanted to mention that research has shown that applying a palliative approach to care early on in the disease trajectory has really shown to improve quality of care, and in some circumstances, patients living longer with decreased anxiety and depression. The hospice definition we had before really wasn't inclusive of the way things are in Alberta right now. Hospice beds can be in a standalone hospice. They can be community supported palliative and end-of-life care bed within a supportive living or a long-term care setting. And that's important to note that that's not just the bed at the end of the hallway that has the extra furniture and extra space for family members to stay overnight, but it has dedicated supports and symptom management supports for that patient, and access to experts in palliative and end-of-life care and their team. Next slide then. So this is a picture and links. In 2014, the framework was developed, and we had patients and families involved with that work, and they really said that the framework was very clinician focused. And so we did a companion document specifically for patients and their families, and they were involved with the development of that document. And most of I'm sorry, I should say there were 36 initiatives that were recommended in the framework. And we're very proud to say that over 21 of those 36 initiatives have been developed, and most of them are housed on the Provincial Palliative and End-of-Life Care website, which Emma is going to be talking about a little bit later in the presentation. So next slide then. So the framework addendum, the Provincial Innovation Steering Committee requested an addendum to the framework be completed as sort of a refresh after 6 years. And this framework addendum has recently been published and is housed on the website. The addendum outlines what Alberta has achieved since the development of the framework in 2014, where we are today, inclusive of current state of programs and services for palliative and end-of-life care in Alberta, as well as existing gaps and challenges and recommendations for future work. It is important to note that in order to implement the recommendations in the addendum, we do require funding and resources. And if you don't know, Alberta is currently going through a palliative review with Alberta Health and MLA Williams. We are expecting recommendations and decisions for funding for palliative and end-of-life care in October. Next slide. So this is a very detailed slide, and of course we're not going to speak to all of this, but these are some of those 21 initiatives that have been completed to date. Some of the ones that are bolded are ones that we are emphasizing for this presentation. And in a few minutes, Emma's going to talk to some of them. Just wanted to point out that the interdisciplinary palliative and end-of-life care competencies were led by the Palliative Institute, Covenant Health, under the auspices of the steering committee, and they are published on the Palliative Institute webpage, of which the Provincial Palliative and End-of-Life Care links to. All right, so if you go to the next slide then. I am going to turn it over to Emma, and she's going to describe some of the key initiatives that might be relevant to you. Emma?
Thank you, Michelle. So as Michelle mentioned, I'm going to provide a very high-level overview of some of the initiatives that were bolded on the previous slide, as well as speak to some of the impacts that we've seen from COVID-19 on palliative and end-of-life care in Alberta. So the first initiative is Advanced Care Planning and Goals of Care Designations, which is a provincial policy and procedure that is required in all settings of care across Alberta. So this program replaced the code-no-code dichotomy that previously existed and is intended to allow patients to identify their preferences for care, including resuscitation, if they should be in a position where they can no longer speak for themselves. Advanced care planning is a very important part of the palliative approach to care. To learn more about advanced care planning and goals of care designation, there's a provincial website that you can see on the slide called Conversations Matter, which is for healthcare professionals as well as patients and families. And there's also resources on the Alberta Health Services mobile app, which provides a lot of great quick references. In addition, I would highly recommend viewing some of the advanced care planning and goals of care designation videos that are on the Alberta Health Services YouTube page. In particular, there's a really wonderful video on somebody who's living with pulmonary fibrosis and why advanced care planning is so important to them. The second initiative is the 24/7 palliative physician on call, which was actually one of the first initiatives that was completed after the framework. This was prioritized because some of the rural zones and communities didn't have access to 24/7 palliative physicians, and therefore patients needed to be moved to an urban center because their family physician wasn't able to consult for symptom management. So the 24/7 palliative physician on-call support is now available to primary care physicians through a program called RAPID, and it is for physicians who need access to a palliative physician to help with symptom management of pediatric and adult palliative and end-of-life care patients. As Michelle mentioned earlier in the presentation, we have a provincial palliative and end-of-life care website, which is a centralized access point that can help patients, families, and healthcare providers navigate what resources are available to them, and learn more about palliative and end-of-life care. This includes a Finding Services tab that you can see on the slide that provides information specific to the zone or area that an individual is living in. And the website is really tailored to be a person-centered approach to care, which includes a lot of culturally diverse and Indigenous health resources with links to virtual hospice, mygrief.ca, and Living My Culture. The website also has a link to the Provincial newsletter and education bulletin, which are published quarterly. The EMS Palliative and End-of-Life Care Assess, Treat, Refer program, it really aims to enhance care in the community. So the intent of this program is to respond to a palliative patient crisis at home, usually due to worsening symptoms. In previous cases, they would have previously been calling 911 to be transferred to hospital. So this program is a non-lights and sirens response where paramedics can assist the healthcare professional to manage symptoms with additional medications, as well as collaborate on the phone with a palliative physician on call or an online medical consult physician. So the goal is to manage a patient's symptoms in order to stay in their current setting of care and avoid admission to the emergency department if that's the patient's wish. This program also includes pediatric palliative and end-of-life care patients with specialized treatment protocols and alert to frontline paramedics that they're going to a pediatric patient's home. So this is the death in the home guideline. So in the past, each zone had their own death in the home form, and there was inconsistent practice relating to the management of death and post-death for palliative and end-of-life care patients. Often 911, police, and first responders were called inappropriately. And because of this, the quality of care for patients and their families at the time of death was not ideal. So this provincial guideline for the patient's death in the home in a home care setting outlines a standardized approach for practice and healthcare providers that leads to improved quality of care for patients and families during an already difficult time. The guideline provides direction on our regulated and non-regulated home care providers on how to prepare our approach for an expected or unexpected death in the home for a patient. During the pandemic, we saw an increase in the number of people who were dying at home, and a checklist for healthcare providers to prepare for patients' deaths in the home care setting was modified to include direction to healthcare providers to ensure that there was a backup plan in case of illness, caregiver burnout, and the ability to isolate in place when required. There's a suite of resources that are available for this guideline that you can see on this slide. These are our clinical knowledge topics. So 3 of them have been developed by the Clinical Knowledge and Content Management Group, one on advanced care planning and goals of care designations, one on palliative sedation, and one for care on imminently dying pathways. So these resources are accessible to external and internal Alberta Health Services staff or healthcare professionals and are available on the link that you can see on the slide. You'll be able to see how important these resources are in some of the clinical case studies that are talked about later in this presentation. And finally, the Rural Palliative In-Home Funding Program provides a special limited funding that can be accessed through rural palliative clients and families when they require additional supports beyond existing services to remain in the home at end of life. This program is unique as the client and family have the flexibility to choose their own care providers and direct and schedule the care they require. This is especially important in rural settings where you don't necessarily have nurse next door type services to support families. So in collaboration with clients and their families, rural healthcare teams will identify and authorize the amount and level of care that is needed, and then clients or their families will arrange the care and their needs and will be supported in navigating the care and payment reimbursement process. So this program can provide up to $10,000 in funding to cover the cost of direct care in home, including personal care, respite care, or nursing care. And these funds are accessed when there is an assessment of unmet need, home care services have been maximized, other services and sources and funding have been exhausted, and additional care is required to safely keep a client or patient in their home longer. So Michael and Amy will discuss this program later on in the presentation from a North Zone perspective. Oops. So before we discuss pulmonary fibrosis and palliative and end-of-life care, I wanted to briefly discuss the impacts of COVID-19 that we've seen in our province. So throughout the pandemic, there have been great strides in virtual consultation to palliative physicians, home care, and interdisciplinary team members using Skype, Zoom, telephone consultations, and other platforms. This blend of services has really increased contact with patients, families, and providers, especially in rural communities. In addition to virtual access to grief and bereavement services, there's an online directory of grief and bereavement resources that's available on our provincial palliative and end-of-life care website. In response to COVID-19, a group comprised of our provincial team, the operational and administrative medical leads for each zone came together to support each other in informal biweekly meetings to discuss shared learnings, challenges, ideas, and resources regarding palliative and end-of-life care operations. One of the first things this group recommended was to have a central, easy point of access for frontline clinicians to have palliative and end-of-life care and advanced care planning goals of care designation COVID-specific resources. These resources are housed on the palliative and end-of-life care COVID-19 SharePoint site as shown on the slide. And to date, the group has helped develop over 37 documents, which have been approved by our Emergency Coordination Center and posted on this external AHS website. An example of some of these documents is the revised palliative sedation quick tips and nursing consideration documents. A pandemic plan for access to palliative and end-of-life care medications was initiated by this group and has been published. And one of the many lessons learned was that outbreak sites were encouraged to more fully utilize palliative and end-of-life care consult services. This group continues to be strong advocates for exemptions to visitation restrictions at end of life. Early on in the pandemic, there was great strife, as Michelle mentioned, around visitation at end of life, both for patients and families, as well as healthcare providers. And healthcare providers felt a lot of moral distress in following the provincial directives for visitation at end of life. As a result, there were debates among operational leaders, town halls with the Chief Medical Officer of Health and the Senior Provincial Medical Director for Seniors Health, patients and families, as well as operational leaders. There was a clarification in what the term end of life meant, as Michelle mentioned, to clarify that it was the last 3 to 4 weeks of life and not just when someone was imminently dying. Throughout the pandemic, there's been a decrease in hospice utilization and an increase in home care utilization. In part, this can be attributed to visitation restrictions, patients and families being afraid of contracting COVID-19 in a facility or passing it on to their family members, closed beds in hospices due to outbreaks, and isolation and not being able to stay overnight in hospice settings as is usually allowed. As a result, there was a substantial increase in home care deaths and patients with more complex symptom management and acuity. This can also be seen in some of the data that we collected back in August 2020 with a survey from home care, hospice, and palliative care consult teams, really showing that the increase in both the acuity and number of clients for home care really increased throughout the pandemic. So in conclusion, overall, the impact of provincial palliative and end-of-life care work on Albertans can be broken down into these 6 high-level categories that are seen on the slide. Now I'm going to pass it over to Dr. Kalluri, who's going to discuss pulmonary fibrosis and palliative and end-of-life care.
Thanks, Emma. And thank you again to CPFF for hosting this event. And I'm very, very appreciative of the invitation. So in the next few minutes, I think what I'll do is try and focus your attention on the need for palliative care in pulmonary fibrosis. And I want to introduce the concept of palliative care being integrated, meaning that you need to start using this approach as you're treating your disease rather than waiting for it as at end of life. As Michelle pointed out, palliative care is really not end of life care. And I think a lot of times I'm having to have this conversation, not just with patients, but even healthcare professionals. So it's very important to understand that palliative care is really a more comprehensive, a more patient-centered approach to care and is different from what we would call end-of-life care. So end-of-life care is part of palliative care, but palliative care is far more inclusive and far more comprehensive than that. All right, let's start with the next slide, please. So as many of you know, pulmonary fibrosis is really a very heterogeneous group of lung diseases. It has several hundreds of conditions, if not more. And more or less, most of them are characterized by a few things, right? They're mostly incurable because that's what fibrosis is, it's scarring. So scarring does not go away. We don't have any medications to date that will dissolve the scar away. What we also know about these pulmonary fibrosis group of conditions is that they tend to be unpredictable, meaning that it's very difficult to predict when you see a doctor in clinic if you know you're going to have an acute exacerbation in a week or a month or even a year. And we know that eventually most of these conditions will progress, resulting in respiratory failure, which is eventually fatal. And what is the other big thing with these disease conditions or this disease group is that most patients suffer from distressing symptoms. Many lung diseases, including pulmonary fibrosis, people have what we call dyspnea or shortness of breath, right? They feel those symptoms of shortness of breath, cough, and fatigue. And as a result, have a really poor quality of life because it's really life limiting. It limits what you can do, it limits what you can enjoy in life. And it just, not only does it affect the patient, but it also affects the caregiver to a large extent. And this is very well documented. And in addition, we know that this group of conditions is also characterized by hospitalizations, simply because we know that there's a lot of distress from these disease conditions that's not being managed well. As a result, when patients cannot cope at home, they don't have an option other than going to a hospital or seeking emergency assistance for their distressing symptoms. Next slide. So last year, there was this very, very nice paper published by a group of experts. And what they did was that they looked at 35 studies that were published between 2005 to 2019, just to document a list of all the kinds of supportive needs that people living with pulmonary fibrosis and their caregivers have. Next slide. And what they found out really was our patients have several needs. Physical needs, of course, are easy to understand, right? When you have a disease that affects your lungs, you have all of these conditions like cough and shortness of breath and fatigue. And that affects how you live your daily life because every activity requires you to breathe and deliver oxygen to your muscles and your cells and your body. So if your lungs are affected, you're short of breath, it'll affect every single thing that you have to do in your daily life. And now that can have tremendous psychosocial impact, especially if your life becomes more and more limited. In addition, we also know that most patients with IPF or just PF have a high incidence of depression, anxiety, and lots of social isolation that happens as the disease progresses. And this, of course, has an impact on family-related issues, what happens to relationships, codependency. Now the caregiver is having to take on a lot of responsibility that the patients were carrying out in their daily lives. So that has a tremendous impact on family relationships. And like we mentioned before, social interactions take a big, big hit. You can imagine that's easy to visualize because as your disease progresses and now you're requiring more and more oxygen, you're probably not able to travel as much as you wanted to, or even get out of the house as much as you wanted to. So that has a tremendous impact leading to social isolation, which again can cause a lot of depression and anxiety, which in turn can cause the symptoms to get worse. So they're all very closely interlinked. And then, of course, patients and caregivers often talk about not having enough information, not just about the disease, but really how to cope with the disease, how to live a fulfilled life as much as possible. So they're talking about a lack of information and a lack of education around a lot of these practical things, including how do I manage myself at home? And of course, when you reach that point in life where disease has progressed, your symptoms are progressing, and now you're facing end of life, how do we plan for it? What should we anticipate? And how do we visualize and how do we think about all of these things and support ourselves well? And then finally, communication was another big piece. Many patients and their caregivers felt that even though they're going to these clinics, whether it's a specialist clinic or an ILD clinic, there's a problem. There isn't good communication between teams and patients, and of course, between patients and their GPs and between GPs and ILD clinics. So that's, can we go back to the previous slide, Emma? And finally, access to care is a huge issue, whether it's access to ILD care or transplant care or palliative care. But what the study showed was that the two big needs that were at the top were information education needs, particularly with respect to palliative care, and also a lot of psychosocial and emotional needs. Let's move on to the next slide, please. So this is a survey that was done by the CPFF, I want to say about 2 years ago, which highlights the same point, that physical needs from the disease, meaning shortness of breath and coughing and fatigue, really affect every aspect of your life, from your daily life, like taking a shower, just walking around in the house, gardening, doing small things around the house. Everything is affected to end of life. Next slide, please. It's clear that over 2/3 of the patients who answered this survey basically felt that their disease had taken over their life, and the caregivers basically said the same thing, that once their loved one was affected, to the point that their activities were affected, it affected the caregivers as well. Next slide. And this is also part of the same survey, which summarizes the extent to which this disease also affects the caregivers. As you can see, most caregivers were in their 60s, most of them were spouses, and they all indicated that they needed more support. So this is where palliative care is really helpful, because it allows the caregivers to voice their needs and to discuss it and feel supported, get some respite. And as you can see, 51% of the caregivers were spending at least 2 hours, and about 11% of those people were spending 6 hours a day. So it can have a tremendous impact on the psychological health of the caregivers themselves and can aggravate their physical conditions. So it's important that we recognize the role caregivers play, we recognize the burden that they're facing, and we find ways within the healthcare system and sometimes outside to support them appropriately. Next slide. So this is the big summary. I think there's a lot of unmet needs in terms of physical symptoms, psychological symptoms that need to be addressed. And this is why palliative care becomes a really useful approach to add to disease-specific management therapy in ILD. Next slide. So this was one of the reasons why ILD experts are now increasingly calling for comprehensive approach to ILD and PF care. What does that mean? It means that besides just getting a diagnosis, an accurate diagnosis, an early diagnosis of your pulmonary fibrosis, and getting things like disease-modifying therapies, whether it's anti-fibrotic therapies or immunomodulatory therapies or referral to transplant, participation in clinical trials, while all of that stuff is important, it should be foremost, we also need to engage symptom relief. So that's the bottom left of the slide. You have to focus on the distress the disease is causing the patients, identify it, and try and figure out what supportive measures can help patients live not only as long as possible, but as well as possible. And you can only live as well as possible if your distressing symptoms, whether they're psychological or physical, are addressed. So really the comprehensive vision for healthcare in IPF is to promote strategies that will alleviate these health-related suffering, make sure you get the right kind of treatments. And once all options are exhausted and there are no more options left and we're facing end-of-life situations, we want to make sure that we also support our patients and their families in that phase of their disease journey. So this approach, where you're not only focusing on disease and disease-based care, but you're also looking at the patient as a person and engaging their caregivers, is what I call integrated palliative care approach, which needs to be the standard approach in medical care. Next slide. So our American Thoracic Society, which is ATS guidelines, therefore recommended palliative care for all patients with IPF. But what is the reality? I think I don't need to emphasize this. Most of you who have been to clinics, most of you who are healthcare professionals know this very, very well. Regardless of in clinics or hospital status or situations, we know that patients are not getting palliative care. So this is an example of a study where you have these 45 patients with PF. And as you can see, those numbers that are highlighted in red, only 38% received palliative care. Even though they all suffered from shortness of breath, they all had irreversible pulmonary fibrosis. Physicians didn't really engage palliative care early. And advanced care planning that Emma was talking about, it occurred in less than 20% of cases. And at end of life, right, this is when we know for a fact that the patient is probably likely to pass away very, very soon. Even in that situation, palliative care was only utilized in 15% of patients, meaning the other 85% died with uncontrolled symptoms, which is really unacceptable care in this day and age. Next slide. So is palliative care feasible? I think I want to say as a physician who's practiced this for almost 13 years in my clinic, it is absolutely feasible. But the question I think most people ask me is that, how do I access this in my own area? And I think this is where a lot of work needs to be done. And I'm happy to report that there are clinics that are picking up this model of care. There are a few clinics in Europe, there are a few clinics in US, and I know my counterparts in Kalluri are beginning to develop it. So while we're not there yet, I'm happy to report that a lot of work is happening within ILD clinics to integrate this. And certainly palliative care is well developed in most of these provinces. And I think more education and awareness is needed so that patients know who to contact and when to contact. So with that being said, I'll take you through a case that we saw in our clinic, just to show you how palliative care can help you from the very early stages to middle stages to advanced disease. Next slide, please. So this is Harry and his wife. He is 72, and I'm just going to skip some of these details in the interest of time. He had IPF. As you can see, he was on anti-fibrotic therapy. His physician had started him on oxygen. His vaccinations, including the COVID vaccine, was up to date. But in spite of appropriate disease therapy, meaning being on anti-fibrotic therapies, Harry was experiencing severe exertional shortness of breath, which is dyspnea, and activity tolerance, meaning that he was not able to do basic things in the house. So when we got him to our ILD clinic, we did breathing tests, we did the walk test, and very clearly realized that his oxygen flows were not enough. He was going down to 78% on his 2 liters, and his lung function showed that he did have progressive disease. Next slide. So when we talk about a palliative approach, it always starts with a patient-centered approach. So besides focusing on the disease, we need to focus on the patients and their caregivers, and we need to identify what their concerns are, both the patient and the caregiver, and then come together as a team to decide what the goals are. So obviously the goal is to identify the disease and treat the disease well, but in addition, what else must we do to improve somebody's quality of life? So in this case, when we asked the patient and his wife, he basically said, I want to improve my breathing. He was quite angry and frustrated because he was not able to do things. He just didn't know what was wrong with him. So he didn't have enough disease education provided. And of course, the caregiver who's now watching all this, watching her husband struggle, is also anxious and frustrated. She wants to know what's happening with her husband. How can she help him? And then she talks about these episodes when he goes in for showers or does small things around the house, his breathing really gets worse. He starts to pant and loses breath and almost feels like they're going to call 911. It gets that bad. So what do? So then once we know what their concerns are, we come up with mutual goals. So obviously the goal here is to improve daily activity, improve his breathing. And now because he's angry and frustrated because he cannot do things, we want to find out what does he want to do, and we want to engage in those strategies to promote those kinds of activities. And finally, essentially, it's about how to live and cope with this condition. Can we get the next animation, Emma? So really, to summarize, his concerns are physical needs, psychosocial emotional needs, daily living needs, and education needs. So if you think back to the original diagram I showed you, this is completely in line with what was identified in those studies. And essentially all the patients that I've seen so far, most of the needs can be summarized and put into one of these boxes. It's one of these conditions. So you have to go into the details and try and figure out what are the concerns. Next slide. So now once you find out what the concerns are, you need to start with what I call patient-centered and family-centered care. So always start out with concerns, identify them. And in order to, next animation, please. Actually, Emma, why don't you run all the animations so it's easier? So once you identify their needs, and you start an integrated palliative approach, the focus is on symptoms, and the focus is on discussion, providing information, providing education, coming up with plans, so that the patients and their caregivers are never feeling alone. They know what to do. And this cannot happen without engaging teams outside. So this is where I'm sure you'll hear from the rest of the speakers in today's events, how important these teams really are. And we have learned that too. So while we have a team in our clinic, we're also very, very closely working with or closely linked with community teams. So that's number one. So in order to address these symptoms and come up with a plan in clinic for all of these concerns, you need to work with teams. So a physiotherapist or a respiratory therapist or a nurse or a combination of those people. And the next principle is the principle of proactive care. What does that mean? Well, if you're at home and you're doing your day-to-day things, you're going about your day-to-day life, you will have these crises of symptoms, whether it's a coughing spell or a breathlessness spell or a combination of both. These can happen. They can come on in an instant, and then people struggle because they don't know what to do. So this is what I mean by proactive care. So clinicians in the clinics need to anticipate these issues and come up with action plans, like written action plans, asking patients what to do. Things might be as simple as increasing the oxygen flow. It might be take an additional dose of the medication for breathlessness, or rest, or change the activity. There can be a lot of different things. And this is where personalized advice is so useful. So these are what we call anticipatory action plans. And it's important to not only come up with these action plans, teach them to the patients, but now this is where you also want to teach your community teams, so that when the patients return home and they have these crises in their own homes, they're not dependent on the ILD clinic or their specialist clinic. They can work with their community teams and get advice. And this is where having access to palliative care physicians, sometimes available 24/7 to their family physicians, might be really helpful. So making up a plan, sharing it with all team members is essential. Because what I've learned is that it really takes a village to look after an IPF patient or a PF patient. You cannot do it alone from one clinic. And then finally, it's not enough to come up with these plans. You also must provide the education and train patients and their caregivers, because caregivers are the first line responders. So unless the caregivers are engaged, we have addressed their concerns, provided them with the education and training. It's very difficult to look after these situations at home very well. And I emphasize that when I talk about education, it's not just about disease education, which is important, but the education must also focus on how to live and cope with PF. Part of it comes from pulmonary rehab, but a lot of it can also be provided through clinics. And the other part is preparing for the future. So whether it's a lung transplant that you're going to, or end of life, because transplant is not an option, both of those conditions require preparation, and palliative care can be useful in both conditions. So even if you're going to transplant, palliative care can help manage your symptoms, allowing you to remain at home, active, and with less distress. Next slide. So the next important component, besides making plans for managing symptoms and coming up with action plans, is how to plan for the future. And that's where advanced care planning really comes to the forefront. It's thought of simply, it's basically a three-way communication process between you, your family, and the healthcare team. And as Emma was pointing out, advanced care planning is really a whole lot more than just a DNR order. It's part of it. So DNR, whether you want resuscitation or not, is part of it. Certainly important to document, but we view that as a much more comprehensive discussion or a dialogue. So let's go through this. In Harry's case, we wanted to find out what his goals and wishes were. So once we had a discussion and Harry found out that he's not a candidate for transplant, he was very clear. He said that he knew he would succumb to the disease. He wanted to pass away in the comfort of his own home. He wanted to avoid hospitalization. And until such time, he wanted to remain very active and enjoy all the activities that he's interested in. So he was very, very clear that those were his goals. So his goals are our goals. The other thing we did was to talk about what his most big fears were. And the fears that I've heard from patients and caregivers are mostly around symptoms. What happens if the symptoms get so bad that you can't manage them at home? Suffocation was one of the big ones on his mind. So we addressed those symptoms. We talked about what death and dying might look like. He was most fearful about being a burden to his family. So we addressed all of these things openly. And how do you address these issues is by teaching patients how to self-manage. So if you know how to manage your coughing spell, if you know how to manage your breathlessness spell to some extent, then you're relieved because you're not as anxious or as worried about those things. Or at least if you know who to call for help, if you have a team in the community that can provide advice to you and guidance to you. Those are the things that are so important for self-management that are often not discussed in clinics and should be. And part of this advanced care plan is also to make sure that the caregivers are part of it, because they have their own concerns and their fears and their worries. And sometimes it's useful to discuss them as a team so that everybody is aware and everybody feels supported. And then finally, the big piece is to document all of these things, all of these discussions and all of these goals, which help us define whether somebody wants to go to a hospital, whether ICU is a good place for them to be, or whether they even should receive medical care, or are we focusing on comfort solely. So those are the different designations that we physicians use. But essentially all of that comes from having a very rich, very open discussion on what your goals and what your wishes are. And there's always a team to support it, no matter what your endpoint is, whether it's to live out a good life, whether it's to go to transplant, or whether it's to pass away at home. There's multiple teams that are always available to support you. Next slide, please. So in Harry's case, when he left clinic that day, we not only covered the disease management issues. So for example, for pulmonary fibrosis, if you're looking at medications, how to manage adverse effects, whether or not transplant was an option. So we discussed all of those things, okay? So that's something that most clinics will do. So what's the new addition that comes with integrated palliative care is all of these other boxes. Symptom relief, we focused on that. We used a team to assess all of those things and provide practical suggestions, including on how to use oxygen. We provided advanced care planning. We provided advanced care planning related discussions, and we brought all of those things and fears out to open so people feel relieved after having discussions. For some of them, it does bring up emotions as well, but in retrospect, most people feel much more comfortable by knowing more than knowing less. And we provide them with practical strategies. We network with the community teams and make sure that they have all of these supports. So this is what I would call is a more comprehensive plan, not just looking at the disease and the medicines, but also looking at all of the other possible needs that patients and their caregivers might have, and to meet them and connect them with all kinds of support in the community. Next slide. So down the road, Harry goes back home. And because we work with the community teams, you can see that we're titrating his oxygen, titrating his medicine for breathlessness. To date, we don't have a very good approach or a very good therapy or a very effective therapy of breathlessness. Morphine, hydromorphone, they work by affecting centers in your brain that sense breathlessness. So this is the gold standard of breathlessness therapy right now. So we placed him on that. And as you can see now, Harry is up and about. He can actually leave his home. He was actually on his way to BC visiting his daughter and grandkids. Because we were able to titrate his oxygen and we kept up with it, we gave him the medicine, we taught him how to use it, when to use it. He's more confident. He's actually able to leave the house and is able to accomplish some of his goals. Next slide. So now 3 months later, he comes back to clinic. Next slide. Yeah, so during the second clinic, he comes back, and now clearly we know his dyspnea, his shortness of breath has progressed. He's not able to do as much as he was doing, say, 3 months ago. His oxygen needs have gone up, and now he's already been admitted to the hospital once. So we know that time is probably limited. We do all sorts of medical testing, including CT scans to rule out other possible reversible conditions. And we now conclude that his condition is simply because his pulmonary fibrosis has progressed. So we prepare the patient and the family. We want to make sure that the patient's goals of care are addressed and they're the same as before. And the principles are the same. You manage the symptoms, you manage the psychological, social support, you review the goals of care, make sure the patient's end-of-life planning is done, provide all the supports. And so because in his case, everything was done and dealt with, it was a smooth transition. Harry was very clear that he definitely did not want to go to the hospital once again. He wanted to pass away at home. So we transitioned him to what we call palliative home care. So we now said, next slide. He will continue to receive all of these supports, but will receive it through the home care teams. And the focus, like I said, is again on managing symptoms, providing and updating the crisis action plan, and continuing to support the patient, family, and the community team. And what I want to do is really highlight in this slide, as you can see here, where it says oxygen 18 liters. So this is how important oxygen management can be. If you're lucky enough to have a team that understands it and can support you, You can live an active life on high flow oxygen at home. And in Harry's case, he was using up to 30 liters with exertion at the very, very end. And those are the doses of his medications. We had increased it from 0.1 to 1. So it's a gradual increment, right? So you don't use very, very high doses, but we use tiny doses that allow the patient to reduce the breathlessness, but also allow them to remain awake and alert and engage with their family, because that was his goal. And crisis action plans are very important because you want to anticipate problems, you want to prepare the family, you want to prepare the patient, and you want to prepare the team. You want to make sure that they know who to call and they have a medication kit at home, because when you're breathless and you're having a crisis, you don't have time to call your ILD clinic and wait for a response. You don't even have time to call an on-call physician and wait for a response sometimes. So you need to be prepared and you need to have these medications in advance. And once you have that and you can use it, if things don't work out, then of course you can call the on-call person. You can call the EMS services who can come over to your home and treat the crisis and support you, thereby preventing you from going to the hospital if you choose to do so. Next slide. So really, when you use palliative care appropriately and in a timely fashion, it allows you both of these things. You can live out your life in a relatively distress-free manner with dignity. You can achieve your goals. And if you've reached end of life, then it also allows you to maintain your goals and have your wishes respected, have the symptoms managed well, have your family supported, and remain functional and independent up until the very end. And even when that end arrives, it is done in a much more prepared, much more supported fashion. And in this case, Harry passed away very, very comfortably in the care of his own family and also at his own home, which were all of his goals that were accomplished. So really, palliative care can help you achieve goals in life. It can also help you achieve goals in your death and also support your family through bereavement. So I'll leave it at that and pass it back to Emma. Thank you.
Thanks, Dr. Kalluri. That was incredible, and it's so great to hear the integrated approach of palliative care then in your program and how we're supporting. Amy and I are going to talk here briefly in regards to looking at the North Zone palliative care team then, and how our team comes together in an integrated palliative care approach as well too, and when we are in the rural settings. And so Emma, if you can go to the next slide, please. So with our team, the term rural certainly covers the majority of the areas that we support in the North Zone. We have 2 urban centers in Grand Prairie and Fort McMurray as part of the 10 operational areas for delivery for care. Our palliative care team is spread out across the North Zone to serve these many different communities. Distances to services are challenging, and if we're physically unable to see a patient in person, we offer the virtual consultation and do our best to support wherever they are located in the North Zone. We also promote delivery of palliative care through education and communication with the care providers across our zone. Multidisciplinary teamwork is an integral part of the philosophy of palliative care and is a key component of palliative care consultants. Palliative care embraces a number of different approaches to meet the needs of the whole person while drawing heavily on a broad spectrum of disciplines, knowledge, skills, experience, and creative thought. Next slide. Our team shares this information and collaborates in a synergistic fashion to achieve the goals of patients and families. With shared responsibilities, more than the sum of the competencies of each team member can be offered. Our palliative care team recognizes that each discipline brings a unique set of skills, and no single team member can meet all of the patients' and families' needs. This allows each of our team members to practice their discipline to their full potential and improves the quality of life while simultaneously reducing the burden carried by any member. It's helpful then for you to understand the roles of our various team members. Next slide. At the center of our team is the patient and the family. We ask, and we encourage others to ask, what matters most to you, as a way of for the individual to directly express their wishes and values, so the care that we provide is according to those. The Serious Illness Conversation Guide helps us to learn more about the individual's wishes to advance care planning so all healthcare team members know what the individual's overall wishes for care are. We use tools like the Edmonton Systems Assessment Screening, which helps us know how the individual rates the severity of 10 of the most common symptoms we see in palliative care so we can address their priorities. Our team seeks to support what matters most to the individual and their family. Next slide. So what does our team members do? We see the patients of all ages in all places as long as they're in the North Zone. This includes Indigenous communities. We are referred to at the beginning of their diagnosis or anywhere in the spectrum until end of life. We prefer early rather than late, as was discussed earlier, so we can provide the best support for the patients and families as they go through this journey. We work under the context of collaboration. The patient's family physician, the nursing and other allied supports are still there as primary supports, and we are a consultation service to provide extra supports and services. We support clinicians and clients wherever they are in the healthcare continuum, including acute care, primary care, continuing care, and designated living. As you can see from the slide, our team supports in a variety of ways. We harness the energy and expertise of our multidisciplinary team to provide evidence-based consultation, assessments, and symptom management recommendations through a holistic approach, attending to our palliative patients' physical, emotional, social, practical, cultural, physical, financial, and spiritual needs. Next slide. So, although the composition of the palliative care team differs in different zones based on population needs, our multidisciplinary palliative care team includes the following team members, as you see on the slide. Our physician has just completed her fellowship in palliative care. Palliative care doctors tend to concentrate on preventing and alleviating suffering and improving quality of life for patients who have life-limiting conditions. This can be given simultaneously alongside curative care. Next slide. Our team is fortunate to have 2 nurse practitioners covering both sides of the North Zone. Both have enjoyed being palliative care resource nurses on the team previously. NPs are registered nurses who have undergone graduate education and training in advanced clinical practice, and they conduct advanced health assessments, diagnose conditions, treat and manage acute and chronic illnesses within a holistic model of care. NPs order and interpret screening and diagnostic tests, perform procedures, and prescribe medications and therapeutic interventions. And so they can have a huge impact on palliative care and family outcomes and provide clinical consultation in any care settings. We do the multifaceted treatment plans in a person-centered approach, and we work collaboratively with the patient's primary care provider. Where there is no primary care provider, the palliative care nurse practitioner may fill that role to support the patient and their families. The NPs also do the advanced care planning that we talked about, as well as providing mentoring to clinicians then in support, as well as they lead in the advancements of palliative interdisciplinary clinical practice in the different rounds and within our team. Next slide. The palliative care resource nurses are registered nurses with a passion to help those who have a life-limiting or life-threatening illness at any point in time in their journey. Some of the palliative care resource nurses have specialty certifications in hospice palliative care through the Canadian Nurse Association. Registered nurses are trained to assess, educate, plan, and implement treatments that are within their scope of practice, and they identify and address symptom management or requirements for other supports and services. Their assessments are very holistic, and it can include anything from vital signs and auscultation, but often lend to more in-depth or hard questions about their symptoms, values, fears, coping skills, beliefs, and even sexual concerns. They also assess the family's questions and concerns as well, and they work collaboratively with individuals and disciplines involved in the client's care to enhance the current plan and assess the implementing various treatments. And so that includes education or advocacy for their overall quality of life and well-being. Our aim is always whatever the client or agent chooses as a goal. Next slide. Occupational therapists focus on maximizing occupational performance. Occupational performance is participating in activities the client defines as valuable. In palliative care, this includes reframing and tailoring interventions to adapt to the client's changing goals and abilities. Occupational performance addresses the client's physical, social, emotional, and spiritual needs. OT treatments plans address loss and grief through enabling patients to continue to engage in meaningful occupations at end of life. And on the slide, there's some of the many ways that OTs help our patients. Next slide. In palliative care, recreational therapy can help by focusing on what is most important to a client, specifically in their leisure lifestyle or free time. RTs design and implement recreation interventions to help foster a continued sense of self-worth and reduced boredom. RTs provide RTs provide clients and families with opportunities to enhance their psychosocial support in an effort to provide the best quality of life. This might include legacy projects, which provide the patients and families a unique opportunity to reflect on their life and processes through events and the people who helped fulfill it. And it can be anything from scrapbooking, t-shirts, letters, cards. There's many different legacy projects. Meaningful leisure is often a result of what are identified legacy projects, and that's what is important to the client and incorporates meaningful leisure to the client's day to help them maintain a sense of self-worth and purpose, which is important for their overall well-being. And then the third interventions we use in palliative care is meaningful family leisure time. And so we see an increase in younger palliative clients from 10 to 60-year-old. And one of the main goals is to participate positive in family leisure time. This may vary between families, but it might be anything from playing cards, doing crafts together. And so we teach about energy conservation techniques as well too, so that they're able to spend that time doing the things that they want. As each client differs, the interventions we implement differ as well. We may use one or two of the interventions above, or all three, or maybe even some not listed there. It all depends on what the client's goals are. Turn it over to Amy here now.
Thanks, Michael. Our team is fortunate to have a CASC certified spiritual care practitioner, which requires a grad degree in theological or divinity studies, as well as a psychotherapeutic counseling modalities. She is a registered member of the Association of Counseling Therapists of Alberta. Our practitioner listens deeply and encourages spiritual reflection, reflecting on personal beliefs, values, identity, and questions of meaning. She supports coping with spiritual distress, the experiences of loss and connection in meeting, existential distress and grief that may arise within the experience of pain, difficult situations, chronic conditions, illness, trauma, and end of life. Supports the healthcare team recognizing the role of the patient and family beliefs in treatment choices and expression of spiritual need. She promotes spiritual well-being in a wide variety of ways as shown on the slide. Next slide. Generally speaking, social work is a health profession that focuses upon improving the health and social well-being of individuals, families, groups, and communities. They work with people to assess, resolve, prevent, or lessen the impact of psychosocial, physical, and mental health related issues. This involves completing psychosocial assessments, providing counseling and emotional support, assessing and providing support with finances, helping navigate community resources, as well as advocating to ensure the basic needs of our clients and their families are being met. Social work in palliative and end-of-life care can be broken down into 5 main categories. Advanced care and end-of-life planning to make sure their wishes are known to the entire health team. Provide education and support with navigating financial and community resources, such as completing financial assessments to ensure clients are accessing the government financial programs they are eligible for, as well as providing assistance with applications. Help with accessing support through programs that are often not very well advertised, and supports they offer are not very well known. For instance, through special needs assistance, seniors can access reimbursement for some home appliances, nutritional products, as well as travel if they need to drive into the city for special appointments. They also assist with health benefits. We will inform the clients of palliative care health benefits and help them apply for them if they are interested. Help explore existing health benefits to ensure they are accessing them to their full extent. Grief and bereavement support. For many of our clients and their friends and families, end of life can be one of the most difficult things we'll have to go through and comes with significant emotional, mental, physical stress and hardship. Social work provides counseling to support the mental and emotional needs of clients and families as they experience palliative and end-of-life care and navigate their journey with grief and bereavement. Also provide information and education on grief and bereavement, as well as they connect to community resources, including other available counseling options or support groups in the person's community. Caregiver support as they travel alongside their loved one, and advocacy for the best possible care for the client and family. Next slide. On our team, we also have palliative care educators. Our clinical nurse educators develop and deliver education that aligns with current best practice evidence and applicable standards and guidelines for direct care clinicians, palliative care team members, the public, and other stakeholders. They plan, develop, facilitate, coordinate, and support the implementation of educational initiatives related to palliative and end-of-life care across the entire North Zone. Our educators are responsible for program delivery based on identified needs, which include legislation, continued competencies, quality improvement, strategic plans, and organizational contractor provider needs. They advise and consult on best practice evidence in the development of education materials and activities. Educators coach and mentor staff and educators to build capacity to provide sustainable education delivery. And they collaborate closely with the zone quality, information management, the provincial palliative care team, and other zones on committees and working groups to plan, develop, and implement palliative end-of-life education materials. Next slide. So teams, specialized centers like Dr. Kalluri's, also have a patient-centered team approach to care, but the members might be a little bit different. This slide shows the addition of a physiotherapist, a respiratory therapist, dietitian to the team with a nurse, physician, and occupational therapy team. As you can see from the role descriptions, there are many specialties that can work for a comprehensive ILD and PF care to help patients and families. If people would like to know more about the role of dietitians, physios, or respiratory therapists, we can expand on this in the question period after the presentation. Next slide. So as an example of how the palliative care teams can support families caring for their loved one is the Rural Palliative In-Home Funding Program that we previously mentioned. This program provides special funding that can be accessed by our clients who meet the following criteria. They are rural, end-of-life patients who wishes to stay home to die, but they have been assessed as having unmet care needs. All home care services have already been maximized, and all other sources of service and funding have been exhausted. Additional direct care is needed to safely keep the patient at home longer. This rural palliative in-home funding is used by patients and families to cover the cost of direct care in the home and to address unmet needs. Direct care can include personal care assistance, respite for our family caregivers, and nursing care. It is important to stress that this funding augments but does not replace home care services. This program is meant to top up services already in place. Next slide. So before we close, we just wanted to take a moment to address the role of the palliative care team in MAID. Essentially, we aim to facilitate a consistent, compassionate, patient-centered approach when we respond to any patient's request for medical assistance in dying. Our team is uniquely positioned to have these conversations with our palliative patients. At the same time, we are not the navigators or purveyors of MAID, but we support and direct patients where to find the information and the resources. Our team's role in MAID is to make patients aware that they have options regarding symptom management and available supports at end of life. They should know they have choices around receiving quality palliative end of life care, and that MAID should be the result of an informed decision. Each of our team's disciplines, professional regulatory bodies, have position statements on their roles and responsibility in regards to MAID. Our multidisciplinary team is qualified to provide psychosocial support for patients who are exploring the possibility of MAID with compassion and respect at the end of life and to meet their wishes.
Well, great. Thank you for this presentation. I have to say that this has been a very in-depth, very broad and knowledgeable, lots of information. And, you know, for those of you who are interested, the Canadian Pulmonary Fibrosis Foundation will have this webinar up on our website at hopereeshere.com and cpff.ca, as well as many of the links here that have been mentioned in the presentation, so that you can go back and further explore this. I've received a couple of questions in advance because, you know, they're sort of generic, just because people were wondering how they can access them depending on where they live in the country. But one of the things that Dr. Kalluri had mentioned was that the Canadian Pulmonary Fibrosis Foundation had done a survey in 2020, sorry, in 2019, to talk about some of the care, some of the gaps that was pulmonary fibrosis patients faced. And one of the things that she had mentioned was 51% of the folks that answered our survey of 700 people who did that, 51% of them said that they did at least 2 hours of personal caregivers duties, and that you know, 11% of them did 6 hours or more. Many of them have submitted questions to say, you know, how do they explore palliative care or any other care in the system that could help them for their own personal well-being, because many of them feel that if they're run down, if they're not feeling well themselves, they can't be the very best for their loved one. And yet they often feel guilty about accessing the system because they think, well, I'm taking up resources that someone else might need. So could one of you address that, about how would someone, you know, access it without feeling, you know, guilty that they are taking up another resource? Because you know, we all understand budget, funding are all very tight in every single province. And how would you help someone to navigate that? Sorry, I think, as I mute.
Just wasn't sure who was going to jump in here, Sharon. So yes, it's quite a common concern then, is people, if they know about the services, are sometimes hesitant to take them and to utilize them. But as the person who asked the question, really great question, it is so important for us to take care of ourselves before we can help other people. And so having that time for respite, having that time so that way the care is met, even that energy conservation that we talk about is so important. And so if you are now more familiar with some of the programs that are available to you, or checking with the healthcare providers in your province to find out what is available to you, please utilize those services, because that is how you're going to save your energy, how you're able to spend that more time with your loved ones and have that best journey possible. And so that's what the services, that's what the programs are for. So really encouraging people to reach out and utilize them.
And also briefly, in the presentation, it was mentioned about rural palliative care access. Many of the folks that have emailed in to me have said that, you know, it's really difficult, although depending which province you live in, there are top-ups and whatnot. But again, because you're in rural areas, it's often not, it's like that individual can come every day to see you, right? Because it's a long ways to travel. You know, does your team see a better way of meeting those needs, or are there any other mechanism that could be in place?
It's Michelle. I think that's one of the huge benefits and need for the rural palliative in-home funding program, which the program was actually leveraged off of Calgary's own, who initially started this program. And the evaluation, the preliminary evaluation results have shown it to be highly effective. And it's just one of a few enhancing care in the community strategies that Alberta has utilized, specifically reaching out to the rural communities. The 24/7 palliative physician on call also helps patients stay in their communities, as well as the EMS palliative assess, treat, and refer program, which is not available in other provinces. It's available in 3 or 4 provinces, but not across Canada. And it's been very effective, especially for rural, remote areas where the home care nurse can access the program remotely and then collaborate once the paramedic is in the home to help. So I don't know if that answered your question, but I believe that we do have some supports that really target rural areas of Alberta. And then I'll just pass that over to if Michael or Amy or anyone else wanted to make a comment about that.
Absolutely, Michelle. We do, like you say, we have some fantastic supports, different ways of communicating and reaching out to the communities, as we talked about virtual consultation and having the team spread out across the North Zone, spread out across the different rural areas, does allow the specialists. But we have to remember that palliative care, although we do have a specialty, can be done in any setting, can be done with all healthcare providers. And so we also concentrate a lot on teaching others through different initiatives across the province on how they can provide the best palliative care, how they can be thinking about what are the best practices as well too in palliative care, starting the palliative care approach early rather than late, and all of these different initiatives that are going on. So that way it's not just the teams that you're looking at here today, but it is the healthcare provider teams that are getting the education and utilizing the palliative care and end-of-life approach. And so I think that's a big component as well too. When we look at these rural areas that we are supporting, we can't be at every death that's present, unfortunately, but we can help others in order to provide the best care possible.
Okay, thank
Sure,
you.
I thought maybe I can just jump in to add, while, I think most of our patients struggle, especially the ones that are living in the rural areas with the uncertainty of it and the burden from the symptoms and the distress. What I have found is that if you are able to implement this palliative approach in advance and engage the teams, while it might feel like it's good to have somebody visit you every day and sort of reinforce what you're doing is good or be there to support you, it's actually not necessary, right? I know it might be a little bit hard for folks to understand. This is primarily because, palliative care is not being implemented early. So as a result, what I think happens is that most patients struggle until the distress burden becomes so high that they actually need help immediately, which is so difficult to get unless you come to a hospital. But on the other hand, if you were providing palliative care early, it would mean that we're anticipating problems, we're coming up with targeted solutions, we're giving them this information in a written format, so patients have that to take home. They're practicing it, right? So when they practice it, they feel empowered, they feel engaged. So there isn't this what I call reliance on the healthcare community too much. They become empowered enough to know that they can look after some of these things themselves. And of course, there will be issues that will need help. And for those issues, when you have the EMS, which is the assess, treat, respond kind of a system where they come in and not necessarily transport you to a hospital, but be there to support you when your own simple action plans have failed. But I think once this becomes more commonplace, integrated palliative care, and we're teaching patients how to live, we're teaching patients how to cope, then they're going to feel more empowered. And then this need that you need to have somebody constantly visit you, maybe even once a week, is gone. Most of our patients who are empowered this way, I find that they probably require an RT or a palliative care person to visit them maybe once a month. And as they advance, maybe that need changes. Maybe when they're really at end of life, they might need daily support. But really, it's about recognizing this early, trying to reach out and ask for written directions on what you might want to do. So when you have that, you practice it, you become more confident in your own abilities to look after things. And I think that's probably the way to go, because the ideal situation where we can support every person living off in the farthest corner of our province with a daily palliative care visit, although we might all want that, that's probably not going to be practical or feasible. And just another plug, I would probably say that there's a lot of work being done on remote monitoring with biometric devices. So hopefully as some of these studies come to the forefront, we understand what these gadgets do, how they can help. A lot of people will probably not feel like they're left out there alone. They're being monitored somehow. And when there's monitoring, there'll be triggers, and hopefully people will figure out that there is a decline before it actually happens and provide that anticipate problems and provide help. Hopefully that answers in a roundabout way, because there isn't a solution right now to provide, daily visits to people. I probably wouldn't even be able to do it within Edmonton, let alone a rural area.
Yeah. Thank you, Dr. Kalluri. A question just popped up. They wanted to know, is there a study that can prove to our governments about the savings that palliative care can actually bring to the system so that it could be better funded?
That's an excellent question. And this one I have a solution to. I actually published a study back in 2020. It was published in a US journal, and we showed that on average, if you just look at end of life and you compare a patient who has received palliative care to another patient who has not received that, there's a savings of about $6,000 to $7,000 per person. Just now you can add, extend it from end of life to the entire disease journey. There's absolutely no doubt that palliative care not only improves the quality of life, not for the patient, but also for the caregiver. It also saves costs to the system that primarily comes from avoiding unnecessary acute care use. I think the problem is not one of not having evidence. It's basically not even policy. As you've heard from the distinguished panel here, AHS supports that. Alberta government supports that. The problem is one of implementation, right? We don't have enough healthcare professionals who are educated, who are aware, who can actually do this. So while we need to make sure there is more evidence, we need to change policy. This is where CPFF working with experts and jurisdictions across is certainly helpful. But I think it's also a lot to what Michael was talking about. It's about educating these primary care professionals and other healthcare professionals and empowering them and teaching them that this has value. Our patients need it, our healthcare systems need it. And I think we as healthcare professionals need it. Because what I can tell you is from my experience, it has made me a more fulfilled physician, just being able to fulfill all of these other needs than just looking after ILD and IPF from the medicine standpoint.
Thank you, Dr. Kalluri. If you don't mind, Dr., if you could share that research paper you just mentioned, that would be really great, because the Canadian Pulmonary Fibrosis Foundation, CPFF, we're always interested in trying to see what we can advocate on behalf of the patient community about their needs, and looking at what's reasonable when we do our advocacy. Like, for example, oxygen, palliative care. These are a couple of critical issues that have been acknowledged by our patient community about some of the services that they're looking for. And so we're trying to find a way, and through the palliative community, how can we all have the same national standards? So it should not matter where you live, you still receive and have access to all the same programs and needs that take care of your needs, right? So those are some of the things that we're trying to look at. So thank you. I'm going to ask our community panel out there, if you have any questions, to please feel free to put in the Q&A, and we'd be happy to answer anything you have. But I think that this distinguished group of presenters have actually been very thorough. And I think most of the questions I received when I looked at your presentation, you've actually answered it. So it's been really great. And I've learned a lot from all of you. And I just appreciate your time and contribution. Thank you so much. I don't see any other questions. I don't know if anybody on the panel have anything that you would like to add to your presentation, your comment about some of the things that you think that the community can do or CPFF can do. We're happy to hear. All right.
Thank you, Sharon. I guess I can just start off by saying I really appreciate having palliative care as an important topic within the September month, the Pulmonary Fibrosis Awareness Month, And I very much appreciate the opportunity to come and talk about it, because I think it brings to light the importance of palliative care. One of the things that I've noticed through my journey with patients with PF has been that palliative care has some sort of an image issue, because lots of people associate palliative care with loss of hope, and there's a lot of negative feeling around it. So I think that's one of the biggest things we have to overcome, both on the public front and on even amongst medical professionals. And we have to start viewing palliative care not as something that's done when there's nothing else left to do, you see. And so really think about palliative care as another tool, right? It's just another tool in your armamentarium to try and improve your quality of life when you're struggling with a disease. And that's all it is. It is basically an approach that allows us to help our patients achieve their goals, irrespective of what happens with the medicine and the disease. So it's really nothing negative about it. I like to tell my patients that palliative care is actually quality of life medicine. That's how they need to think about it. It's absolutely positive. We do it with a sense of hope and optimism. And the hope and optimism is to have the best quality of life, no matter what the situation puts you in.
Thank you, Dr. Kalluri. I have to say that I used your exact sentiments many times since last year's presentation that you did. And I keep telling people this is like another, drug therapy. It's positive. And so I've been trying to promote that as well. So thank you so much for this. I want to thank everybody on the panel. Thank you all for coming on today. And we look forward to, you having some more information later on. And that's one of the reasons why our Pulmonary Fibrosis Awareness Month is called Hope Breathes Here, because hope does breathe here. We try very hard to bring hope and positivity on your journey. And we know this is a very difficult journey to go through. So thank you all.